Pulmonary complication in the acute phase: pneumothorax, hemothorax, aspiration, pulmonary edema, pulmonary embolism, respiratory distress syndrome in pediatric, respiratory distress syndrome. High clinical suspicion, early screening, red flag, done in patient with high cervical spinal cord injury. Red flag include alteration in breathing pattern, persistent tachypnea, tachycardia, early fatigability, inability to participate in the therapy. Any febrile episode or drop in the saturation should prompt the physician for early septic screening, blood gas analysis, and radiological evaluation. Early mobilization, vertical orientation, prime importance. Respiratory exercise help in improvement of respiratory muscle strength, vital capacity, residual volume, weaning of patient from ventilator, if any. Incentive spirometry, single breath count, single breath count, breath holding time, commonly used in bedside evaluation to assess respiratory function. Atelectasis, pneumonia, and respiratory failure are commonest cause of death in acute phase. Atelectasis, pneumonia, and respiratory failure are commonest cause of death in the acute phase. In case of weak or absent diaphragmatic function, child may need ventilator support. If intercostal and abdominal muscles are weak. If intercostal and abdominal muscles weak or non-functional, functional diaphragm, cough assistance, respiratory asphyxiation management, ventilator support during respiratory illness or while sleeping, assisted coughing only requirement in the weakness of abdominal muscles only. Percussion and postural drainage complication, percussion and postural drainage, insufflation devices, percussion vest, assistive cough technique, prevention for atelectasis and secretion management. Few important steps for maintaining respiratory health include vaccination, pneumonia, influenza, adequate nutritional support, respiratory muscle training, introduction of cardiopulmonary fitness program, early mobilization and respiratory muscle training regime, improve exercise muscle strength, vital capacity, residual volume, wheelchair interval training, providing trunk and abdominal support help in improving ventilatory capacity. Mechanical insufflator, exsufflator to prevent mucus plugging 2 or 3 times per day. Mucus plugging is common in those with weak cough reflexes. Assistive cough known as quad cough, forceful push of upper abdomen at the end of deep inspiration, mimics a true cough. Procedure can be practiced by removing thick secretion. Chances of developing infection, atelectasis, respiratory failure minimized by early weaning. Diaphragmatic pacing, phrenic nerve pacing, and combined intercostal and unilateral diaphragm pacing technique in selected cases. Regular range of motion exercise, preventing the development of chest wall contracture, and lung restriction from muscle weakness.